going to another piece now, which is what we call the expert view. Data and Doctors is the title, Boosting Uptake and Preventing Illness. So introducing Dr. Martin McShane. Dr. McShane is the Chief Medical Officer at Optum UK, which is a part of the United Health Group. With the responsibility to lead the clinical team, support strategic insight, and oversee safety of digital health products such as population health management solutions, and so on and so forth. So without further ado, Dr. McShane, please come up here, and please welcome Dr. McShane with me.
Thank you very much. Good morning. It's a real privilege to be with you here today. As I was introduced, I'm the Chief Medical Officer in the UK for Optum, which is part of United Health Group. So what qualifies me to talk to such an august audience? Well, I'm a somewhat rare creature. In my medical career, I've been a surgeon, I've been a general practitioner, and then I moved into system management and became an executive in the NHS locally and regionally. And for the last 3 years of my time with the NHS, I was the National Director for Enhancing the Quality of Life for People with Long-Term Conditions, one of my snappiest titles. For the last 7 years, I've worked for Optum in the UK. I only meant to stay a year, but the insights working with linked data with analysts has given me has meant I found it impossible to leave. It's hugely energizing and exciting, and I've been able to do the job I've always wanted to do. I've also been able to draw upon some of the US assets and experience and insights, such as the Optum Labs data warehouse, which currently manages and leverages one of the biggest linked data sets of de-identified health records in the world, 265 million lives. A similar order of magnitude to the European health data space intended to bring together data of 450 million EU citizens. Based on my experience and insights, I want to persuade you that using data in the right way is transformative for health and care. Healthcare in Britain, in Europe, in Japan, in the world is facing similar challenges, such as an aging population with more complex needs and more complex care available. We also have similar workforce challenges, but we also have similar opportunities, and I believe that one of the most important ones is data. 30% of data stored globally is health data, but only a fraction of it is used today. Most of it sits in silos. It's disparate, it's not linked, and the potential, the value that data could create is not being realized. Now, as a doctor, I want to measure my work using the best principles: better health outcomes, better experience of care, better job satisfaction for me and my colleagues, and a better use of what will always be limited resources. Creating linked health data sets and better use of data will help us deliver a better system of care. And let me illustrate it with just some simple examples from work we've done in the UK. In England, we partner with the National Health Service in population health management, which you may know is a data-driven way of understanding what is happening to citizens in our system of health and care. It starts and is centred around the person, their complexity and risk, and builds right through to a population level using de-identified data. It's a way of taking the data from every organisation, primary, community, mental health and hospital care, and linking it. But we can also add in social care and overlay that with wider determinants of health, such as housing and employment. And we can create an understanding of what is happening to an individual, to a family, to a community. And it allows clinicians who have the only permission to re-identify using that data to develop an understanding of the individuals with the highest risk of ill health and being hospitalised, and develop personalised plans for them, drawing on the strengths of the whole health and care system. For example, let me give you one. During the pandemic in Norfolk and Waveney, the central data analysis identified 30,000 people at high risk who should shield early in the pandemic. We used a population health management approach and identified a further 12,000 people who should be advised to shield. Almost a third of all really vulnerable people were missed before, as their health data was not linked. Another example is relevant to the current energy crisis. Cold homes adversely affect health. We're working with a system to identify individuals with such a risk, and we've currently identified 1,200, a cohort of 1,200 people with chronic obstructive pulmonary disease.
You know what? This is making a noise. I'm just gonna. I think that's better. Try it.
Okay, I'm going to try it now. That's brilliant. Thank you very much. We've identified 1,200 people with chronic obstructive pulmonary disease, a 50% risk of an emergency admission in the next 12 months, who are fuel poor. And this insight will be used by local services to prioritize this most vulnerable people cohort of people and provide them with fuel allowances and anticipatory care. Over the last 2 days, you've heard a lot about the huge potential of digital transformation in various sectors of the economy and society and links between them, and health is one of those. But I hope maybe you can sense from what I've just told you that there may be interoperability with other data spaces, such as the energy data space. And I'm going to come on later to talk about skills as well. I know that the European health data space is not just an aspirational dream. It can be done because I've seen it done in our Optum Labs data warehouse. 10 years ago, we created this data warehouse with the Mayo Clinic to harmonize medical data recording and open its use up for wider research and healthcare product development. Today, it has over 30 partners, government health agencies, research institutions, and non-profits. There are 10 to 15 research programs going on at any given moment in critical, challenging issues such as diabetes and cancer. It's been central to over 130 research programs. The additional value of having a live data set of 265 million people is it can complement clinical trials with real-world evidence, as we saw brought so much rapid benefit in the pandemic. Although the data is located in one country, it is a hugely fragmented healthcare environment with numerous hospital systems, clinical networks, and healthcare payers all deploying separate systems for medical data capture and storage. We deal with similar issues of complexity that the European health data space will have to address as well, but it can be done. And its impact could be phenomenal. It's an opportunity to reinvigorate the way we plan and deliver care. Not only can we improve the management of single conditions, such as heart failure, we can also learn how to tackle the rising tide of multimorbidity and track the beneficial impact of integrating care in preventing health deterioration and how resources are used. However, such a huge health data lake is not enough. It needs to be given meaning with professionals with the right skills and understanding. We need data scientists who can work with health data and in a meaningful way with clinicians. We need to value the meaning such data is given with the knowledge and experience of frontline clinicians, which is why new specialities are emerging, such as clinical informatics, chief clinical information officer, and pharmacy information officers. And at United Health Group, they created such rules to champion digitally driven transformation in our sites of care. And just last month, the NHS in England introduced a chief clinical information officer and deputy. It's becoming more common for data scientists and clinicians to work closer together in care planning and delivery as the impact is becoming more widely recognized. After our program of development in one city in England, all the leaders of several organizations came together, collaborated, and pooled their scarce analytical resources to create a central office of data analytics to power their journey towards population health management. Working with linked data in partnership with the NHS, local government, and the voluntary sector, I've also seen the impact it can have on the morale of health and care workers. I've had doctors saying that this new way of looking at the problems they're facing has given them their job satisfaction back. It aligns with their motivation and experience and helps them do the job they want to do, making the health and care system work better for everyone. I truly believe that the European health data space will greatly contribute to better health and care. Giving terabytes of health data real meaning will have a profound impact on improving health outcomes, help overstretched healthcare workers, and help them make informed decisions, and will help health systems become more effective and efficient. But, as you've already heard, to make this happen, data is not enough, so I'm going to echo. It will require trust. Trust among patients and citizens that the data they allow use of is being used with good intent and never misused to disadvantage them. Trust among clinicians and researchers that the data is reliable, their insights are valued. It will require a change of mindset, and the European health data set is a change of mindset. It requires the resources and skills to realize its potential. I hope I have persuaded you that using linked data will help drive the transformation needed, and I believe that it is within our collective strengths to make it happen. Thank you.